right. Good afternoon, everybody. I was just saying I chose a really long way to get here, which might be a metaphor for value-based care. We'll see in a moment. But I'm very happy to be here, and I just want to thank Nelson Mullins for organizing this conference. Value-based care is a very hot topic. It has been a topic for many years. And I would just love to call out the gentleman in the back of the room who shared with us an agenda of a conference that I believe he spoke at or organized. I think he said 20 years ago, 25 years ago, and 2011. And the title of that conference was ACOs, Will They Become Reality? So I think that's just a fun little nugget to start with, to acknowledge that this is really more of a journey. Value-based care, value-based contracting, it's not a moment in time. It's not even the contract that is important. We're going to actually talk about that today. It's really a journey that our entire healthcare system is on. And so it is important, and that's what I'm going to tee up today with, to understand the ecosystem, the evolution of all of these concepts, because if all you do is sort of sit and think really deeply about contracting and just the contract and just what goes into the contract, there is no possible way we will be successful in a move to value-based care. And that's what I'm going to talk about today. So I'm going to start us off. I'm the Chief Solutions Officer at Helgerson Solutions Group. We're a boutique consulting firm in New York. We do work all across the country. The focus of our work in healthcare is the move to value-based payment. So we work with ACOs, providers, provider groups, payers, plans, sort of whoever needs help, whoever's on this journey and needs some assistance along the way. And we'll talk about a couple examples, and I know I'm not the only one who's going to talk about specific examples to give you guys some hard and fast examples of what we're talking about. So just kind of a quick outline, we're going to talk about, let's start at the beginning. What is value-based care? What is value-based contracting? Why is it important? This goes back to some of the philosophy that I want to leave you with today. And then we're going to get into the strategies for success. But first of all, right, if this is a journey, we have to understand where it is we are going, right? We have to understand what is the end state that we're trying to get to. And when you look around, defining value-based contracting or value-based care, it's harder than you think. And there's a lot of conflicting definitions out there, and I think it's important for us to just sort of name that. Across the care industry, we see different acronyms and names for what it is that value is generally trying to create. So you sometimes hear about VBC, value-based contracting. What about an APM, an alternative payment methodology? VBP, value-based payment. All of these are sort of synonyms for the same thing. And so as we start talking about it, you might hear me sort of switch in from one or the other. Just know we're all sort of talking about the same thing. But sort of philosophically, what is the future state that we are trying to create? Because I think sometimes it's really important to just name that the way we deliver healthcare in this country and others, point blank, is not sustainable. And we will financially and otherwise ruin this country. And by the way, we're not the only country that faces this problem if we don't somehow solve this problem. So I hope you all in the next couple hours came with solutions and we can solve it, right? Thank you, excellent. He's gonna get it done. So again, this is a larger movement. Value-based care is not a US phenomenon. It's happening all across the world in lots of different ways, across lots of different delivery systems. I think sometimes we often play this game. We think we're terminally unique, right? And I think the other place we think is terminally unique is the UK with a national health service and a single payer system. They are also moving to value in ways that are highly similar to how we're doing. So I also place that nugget in your brains for today is as you think about how you want to do something, don't hesitate to look around the world. There are some amazing examples. I'll give you a few today, but you should really see this as more of a global opportunity. And there are some nations that are far ahead of us, and we should learn from what they learned in early days as well. So I selected just a couple of definitions for us to kind of just look at, just so you guys can start to see sort of who's highlighting what. This one comes from the American College of Surgeons. I think this is, to me, the closest to really defining the problem that we're trying to solve. So a value-based contract is a written contractual arrangement between parties in which the payment for healthcare goods and services is tied to a predetermined, that word being incredibly important, mutually agreed upon terms that are based on clinical circumstances, patient outcomes, and other specified measures of appropriateness and effectiveness. A lot there, but you can start to see how we're sort of defining the contract is one thing, but what are we trying to tie? The payment of goods and services and the outcomes that you want. That's really at its core what value-based care and what value-based contracting allows to happen. This is CMS's definition of an alternative payment model. Model or method sometimes gets interchanged here. This is an approach that gives added incentive payments to provide high quality and cost efficient care. It can apply to specific clinical conditions, a care episode, or a population. Again, we're talking about cost, quality, and how we're going to arrange those two things in a contract. This is the American Academy of Family Physicians. This is the concept by which purchasers of healthcare, such as government, employers, and consumers, and payers, hold the healthcare delivery system at large accountable for both quality and cost of care. So you can see everyone's saying it a little bit differently, but you start to see the common threads here, right? Payment, cost, quality. Somehow we've got to get that in a box that we can all agree to and work towards better outcomes on that. Now to add some complexity to all of this, right? Some of those were CMS, right? So national payers, some of those were, provider groups. Every state is starting to define VBP slightly differently, right? So now we're starting to see actual differences in how the states, especially when it comes to Medicaid programs, which of course, as you all know, are federal state partnerships, and the states get to define some of the terms. This is New York State's value-based roadmap. New York State is a very advanced state when it comes to value-based contracting. We spent the last few years in a program called DSRIP, where we accepted $8 billion of federal dollars to reinvest into the healthcare delivery system for Medicaid in exchange for coming out of that period with 80% of contracts. 80% of all Medicaid dollars are in value-based contracts today. 36% of those are in high-risk arrangements where there's significant downside risk. So you can kind of start to see there's still a lot of activity in just the no downside risk for providers. So this is available online. The interesting thing that I'll just point out is that this document is a CMS approved document, and yet they allowed New York State to define value-based payment slightly differently than how CMS. I anticipate this continuing to be the trend. I know we just did some work in Washington. Washington has their own value-based payment definition. So you're going to start to see some nuances. This, of course, creates complexity, especially if you're working with providers or ACOs who are across different states. So this is absolutely something, especially if you're an aggregator or seek to be an aggregator, this is something you really have to pay attention to, really ensuring that you understand how states are defining VBP for specific business lines. So what are the limitations of all of this complexity? First of all of these working definitions tend to define value quite narrowly. As you can tell, there's usually a cost component, there's usually a quality component. What we typically mean when we say total cost is the claims cost. So, right, so how many dollars did an individual spend over the course of a particular period? In performance, we tend to look at standardized healthcare measures, HEDIS measures, and others, things that have been widely tested and agreed on. The reason we want to bring up to you that this approach is a little bit narrow is you're leaving out some other indices that perhaps there isn't a HEDIS measure tied to it, but we really should have our eyes on this, right? So things like increased quality of life. How do we really pick up how value-based care enables individuals to have just plain English, better lives? Some of that isn't always picked up in a HEDIS measure. So how do we start developing measures that can capture some of this? Reductions in medical malpractice costs. That's a huge one. We did some work for an MSK operator, right? So that's one of their biggest OBGYN providers. That's some of their biggest concerns as groups is the cost of medical malpractice is very, very high. And so how can value-based contracting, how can value-based care ensure that we get better clinical outcomes and reduce that risk? Reduction in membership churn. You talk to anybody pre the public health emergency, and soon when that ends, membership churn is always a challenge, especially for Medicaid plans. This is always something that's top of mind, but Medicare Advantage plans also face some churn. So I want you to definitely kind of stick with the original definition of cost and quality, but I also encourage you as you go through these exercises and through these contracting, think about what other externalities can you impact. This sometimes is an accelerant in contract negotiations. Yes, we'll do the HEDIS measures. Yes, we'll do total cost of care, but hey, let's look at this other thing. Right. So just as an example, we're in the midst of negotiating a value-based contract for maternity bundles, right? So we have maternal indicators, we have indicators for the child, but what about this other thing, which is a lot of plans struggle to capture the child as a member after the child is born, right? So that's something that's not a HEDIS measure, but it's something that we're working towards including. Long story short, we really have to expand our thinking when we define value-based contracting and what the measures are that we're working towards. So why is all of this important? That's a good question, and I hope you all have at least a small answer to that for being here today. But value-based contracting, at its core, it is a means and not an end. And too often, as a consultant, we are brought in with that being the end goal. And that is the very first thing I tell our clients. If you just want a contract, you're looking at the wrong measure of success. Individuals who climb Mount Everest do not measure their success as reaching the top. They measure their success by making it back down the mountain. Because if all you do is focus on getting to the top, you will die. If you extend your thinking and say, I have to get up, but I have to come back down, you will start to prepare in the right ways. And I think that is an apt metaphor for all of the attention that is placed on value-based contracting. It is reducing total cost of care and improving quality that is our real North Star. And we have to be very, very clear about that. I think oftentimes we get bogged down in the nuances of these contracts, risk adjustment, capitation, what performance measures, what's our baseline, how will we adjust if our patient population gets riskier? These are all really good questions, and we're gonna dive into that somewhat here today. But at the end of the day, if you don't inherently see value-based contracting as a means for financing new care models, care that is inherently different from how we treat people today, you will get a value-based contract, but you will not have radically changed healthcare. And so we really have to see the two together and not one or the other. Value-based care is also not about just doing things, doing more things. And I encounter this a lot, right? Someone will say to me like, well, we think we have this really great program and we just wanna replicate it. And then I ask that next most dangerous question, how do you know that that is working? And oftentimes providers and provider groups cannot answer that question, right? And so just thinking that you're doing something differently does not necessarily mean you should replicate it. In fact, it is quite a danger to replicate things that you don't really inherently understand if they're having impact on either quality or cost in a value-based arrangement, because you will proverbially lose your shirt, right? Because you'll spend all this time implementing programs that you don't actually know, and perhaps when they scale, they actually don't lower total cost of care or improve quality, and you will be out that difference because that's what value-based care does. Value-based care and contracting should be about provider empowerment, right? Healthcare reform, if you want to use that word broadly, including the young man in the back with, who was here all those years ago. I'm sure that was also a conference about healthcare reform, right? We have really, really empowered provider burnout to take place. And whenever you talk to provider groups, it is the #1 issue that I hear over and over again. And at the end of the day, if your providers are burnt out, they are simply not providing good care. And so we have to look at value-based contracting as another avenue to reduce administrative burden from our providers. And when I say providers, writ large, right? Not just physicians, all clinical and non-clinical staff. You all know this, EHRs, clinical protocols, process improvement, quality measures, all of this has made it very tough to be a clinician in today's world. And so how do we use the mechanisms of value-based payment to try and alleviate some of that burden? If we don't do that, we're just adding another level of burden. And that does not decrease burnout. That's going to accelerate burnout even faster than the rate that we're seeing it now. We really need to use this opportunity to get providers out of the coding game. And by coding, it's not just risk scores, it's a lot of coding games that we play right now. How do we allow them to innovate by offering really personalized care that is both better care and overall less expensive to the full system? If this kind of thing doesn't happen, if this broader shift in culture doesn't happen, value-based care and value-based contracting simply will not survive. I have been involved with other large reform efforts in other sectors. And the thing I wish I could go back in time and tell myself is that this is a really good idea, but there is a shot clock that has already started and you don't even know it yet. And if enough time goes by and we provide not enough good experience to payers and providers and ACOs and whoever you are in this ecosystem, there will be a point in time where we collectively go, that doesn't work. Value-based care, value-based payment, we tried that. It doesn't work. So I am here partially to warn you that that shot clock has already started. And if we can't do enough to prove that this works, we will simply move on to the next healthcare reform idea. I don't know what it is, but someone will surely come up with one. And then we'll spend the next 20 years trying to do that. So we need to be very, very cognizant of this fact. Aha. Value-based contracting, value-based payment also should allow us to meaningfully address social determinants of health needs. I know that the social determinant of health word has been a buzzword for many, many years now. We're going to have a panel talking about equity. We can kind of dive into some of this. But at its core, if value-based care and value-based payment allows maximum flexibility, we should always be allowed to do the thing that is right by the patient. And a really tangible example of this is there's a large healthcare system in New York City. They're the largest. They serve the South Bronx, which is one of the most impoverished areas in New York City. And a group of doctors there, they have been pioneers in value-based arrangements for many, many years. A group of doctors there started realizing that their COPD patients were starting to hit the ED and get sent upstairs for inpatient stays when the temperature got hot. But they kept seeing this pattern replicate itself over and over. And so someone finally took the time to step back and look at the data, and they said, yes, every time the temperature goes over 80 degrees, we see this huge spike in patients coming in. And so they started investigating. They started asking the patients, what is going on? And what it turned out to be were that these were low-income residents who lived nearby in public housing, very high towers that did not have air conditioning units. And so all of a sudden they started feeling constricted, they started feeling panicked, and they would call EMS, and the FDNY would go over, and they would take the time to bring these folks down the back stairwell sometimes of these old aging housing projects, and then they would go to the ED, and then they would have an inpatient stay. And you all know the cost of that. What the healthcare system did was they tried a really small test of change. They started buying air conditioning units for $400. And they actually sent a maintenance person over from the hospital to go install those air conditioning units in those people's homes. And then they waited, and then they looked at the data, and those folks no longer hit the ED when the temperatures went up. So this isn't about coding. This isn't always about screening for SDOH and coming up with some complicated plan about how we're going to get reimbursed. When you are in value-based payment arrangements, when you have maximum flexibility with the dollars in front of you, you can do what I call the next right thing for the patient. You can meet their need without filling out 100 pages of paperwork. In England, the NHS has this program that is now a national program. It's called the Red Bag Program. This is another example of local innovation just taking shape. What they had was essentially nursing homes, which are not financed by the healthcare system. It's financed by local government. They would send in patients if something happened, in the care facility. They'd send them over to the hospital, and then they were waiting, and the length of stay just kept getting longer and longer and longer. Folks were inpatient for many, many days. And so finally, a small group of nursing home staff members came together, and they said, well, let's try and get to the bottom of this, because length of stay in a hospital is very expensive. How can we figure out why the length of stay is going up? And they started interviewing discharge nurses. And what they found out was that when the individual came into the facility, came into the hospital, They came to a sort of a jumbled mess of like, obviously there was an acute breakdown going on, but they came without information about where to send the person back to. And oftentimes this person would come with glasses, dentures, personal effects. And by the time they had figured out where this person needed to return to, they had lost all of those pieces of that person's dignity. And so now, today, there's a program called the Red Bag Program, which is in nursing facilities. Every individual who is there has a red bag, and it's essentially a go bag. It's acknowledging that at some point you probably will have to get transported to the hospital, but it has clear instructions. What does this person have? What pre-existing conditions? What tests have been done lately so you don't have to rework up the patient when they get to the hospital? And this is where they need to be discharged to. And these are the things that they took with them: glasses, dentures, personal effects, right? That is simple. That is not an EHR integration project, right? Like, that is simple stuff, but they have seen length of stay reduced with meaningful impact. So this is what we're talking about when we talk about value-based payment enabling social care that really impacts patients in the way they need to be impacted. This is not about new billing codes. This is not about working up a whole new system of payment, because guess what? If we're going to put together a whole new system of payment for social care, we're probably going to get it wrong, right? We're probably going to make it just as complicated and ridiculous as the current system of payment is. So let's just not do that. We are very much in the early days of this. There's a lot to learn. There's a lot of innovation happening. These are two examples, but we know that there is really good stuff happening all across the country and all across the world on this one. All right, so creating a contract. So to get to all of these wonderful outcomes, to get to reduce length of stay, to get to reduce cost of care, you do need a contract with achievable outcomes. And one outcome, there we go. One of the biggest things I get asked a lot is, where do I start? Maybe I don't have any value-based arrangements, or maybe I have some and they've been unsuccessful. And I think what we kind of get stuck in is we have to be fully ready before we begin. And I'm sort of here to tell you that you really just got to get started. And that's really the hardest part. If we wait until we are fully ready, we will never begin. And we should look at value-based contracts and value-based programs as an iterative process. So really, I always ask folks, do you have a willing and able partner to negotiate with, right? Do you have a plan? Do you have a partner, whoever that payer is, that you can go to and say, hey, this is a goal of ours to be in value-based arrangements. Let's sit down and chat. The second thing you really have to have is a general idea of what kind of contract you want to create. What are the care differences that you want to see happen? Perhaps you're serving a subpopulation, folks living with HIV. You want to see a reduction in, how many days of inpatient those folks have that are related to, their condition. I don't know, whatever it is. But make sure you have a general idea of what you're trying to get to. Creating shared understanding. And I realize the irony here, right, is before you launch into any kind of contracting, I always say before you call the lawyers, right, make sure you have a really good shared understanding about what both parties want to see achieved. And that can be as loose as just a tiny vision statement on the back of a napkin that just sort of encapsulates what are we trying to do here, right? Just saying lower cost of care and better quality, that's not going to cut it, right? So here's an example of a contract that I created and executed. Create conditions for high cost, high need HIV positive patients to thrive by creating a model that reduces cost, improving quality of care, specifically around viral load suppression. Okay, this isn't a contract, but what do we know? We know it's for people living with HIV. We know we want to see higher rates of viral load suppression. We want folks to thrive. We want to reduce costs, right? Like, we're starting to get narrower and narrower. I often tell folks, if you don't have a vision statement that you can't come back to later when the negotiations break down, as they will because they're contracting negotiations, you're going to have a harder time bringing people back to the table. And so just having a document early on that says, yep, both parties agree this is generally what we're trying to get to will absolutely help you get there. Another thing that is hard to bring over into the healthcare world, this is from some work that I've done outside of healthcare, is to really look at every conversation as a cross-sector partnership. It is mind-boggling to me sometimes when you meet payers and you talk to them for 20 minutes and then you talk to providers for 20 minutes, you would think you're in two different countries speaking two different languages, right? So you need to acknowledge that, and you need to look at every single conversation as a cross-sector partnership. So you're gonna have to roll back and say, okay, when you say attribution and you say attribution, what are you both saying to me? Because I'd say 75% of the time, they're actually addressing different things. So creating common definitions, working through that muscle of understanding that these are, yes, it's all under one sector. Yes, it's all healthcare, but we all live in very, very different worlds when it comes down to this. The terminology, the experience, there's this thing called mental models. If you all are familiar with this is sort of the way we view the world. A lot of folks go through the world with very different mental models. And if you're not sort of standardly addressing that over time, you're gonna have real rifts in the contract negotiation process. The other thing you have to acknowledge is that you're going to be working with large groups of people from either party. So you're going to be working with legal representation, you're going to be working with clinical representation, care management representation. You're going to have to talk about this contract until you are literally blue in the face and you know it like the back of your hand. And you might have to start over and over again with that definition. So the better you can become clear, practicing becoming really, really clear with folks, this will accelerate your time to contract. The thing that I always say is clarity is kind. Unclear is unkind. And the clearer you become, the faster you will get to contract because more people will understand what it is you are actually talking about. Before reaching for contracts, before reaching for the lawyers, make sure you have a high level outline between both parties about what the contract terms are going to look like, what is going to be in and what is going to be out. Especially when you're early in contract negotiation, it can be helpful to just say, you know what, this is a pilot. And whatever we create here, we're only going to put 1,000 lives into it. Now everybody breathes a sigh of relief because now you're not trying to get, 500,000 patients into this contract. So just creating that, very high level term sheet to get people to understand what's going on, that will help. That is also a document that the opposing side can bring into their other staff meetings, conversations that will replicate conversations that you don't necessarily have to have. These are some high-level things that I usually include in this document. Attribution or population, how are we going to know who this contract applies to? That's a really important one. What's your target budget methodology? Are you going to go based on historical claims or using a geographic, regional benchmark? How are you actually going to get to the target budget? The financial arrangements, is there going to be a capitation? What level of risk is this? Is there upside, downside risk? How are you going to mitigate that risk? Are you offering stop loss? No. All of those just high level, not the details, but getting that onto a 2-page piece of paper. What quality measures? Most importantly, what data are you going to exchange between parties? How are we going to know what is happening clinically and also on the payer side? High level, again, don't get into the APIs here, but just sort of high level, we'll share quality data, you'll share claims data, great, we have agreement on that. A DOFR can be very useful, typically not this early in the process when you're still just sort of sketching out what's in the contract, but ultimately, oftentimes, especially with bundles, you do need to get into a detailed DOFR, Division of Financial Responsibility, sorry, should say that out loud. So now you have this, right? You have tentative agreement between two parties that this is what they want to do. They both agree, we want to get into this value-based contract. Now you really have to focus on the contracting. The structure of the contract varies wildly between different plans and different providers. And that's just a reality. If you are an ACO, an aggregator of physicians, there's just no way around this. Oftentimes plans have a structure of their model contract and it will vary. My best advice is even when you're just in the very early days, just ask for a copy of their model contract because it's going to take you a couple weeks to even just wrap your head around how do they structure the contract? What is the actual just sort of, logical model that they're using? Both parties should decide which team's legal counsel will draft the first draft of the contract. This oftentimes doesn't get done and both sides start drafting a contract and then of course there's mayhem. So go ahead and just name it and say, whose legal team is going to draft this contract so we can get started. Ideally, especially if you're working with provider groups or just contracts that are across multiple states or in different regions, use whoever's legal team actually has knowledge about the relevant regulatory body. So if you're new to a state and whoever is on the other side of the contract has been in that state for many years, it is typically wise to use that person's counsel just because they know the intricacies of the regulatory space that you're working in. If you start getting into value-based contracts, especially those that have to be approved by a certain regulatory body, go ahead and replicate those, right? If you have a structure that works, keep going. Don't feel like you have to create new cloth contracts every time you put together an arrangement. Entering the negotiation phase. So I'm a pretty type A person, so this is my favorite part, is once you get to a pretty good understanding of what's going on, you really enter this negotiation phase. One of the things that often doesn't happen is naming a specific negotiation team and a lead negotiator. Oftentimes, especially if you're new to value-based contracting, you want to name an outside negotiator. This can just sort of help speed the discussion along. They can answer questions about, do people do it in this way, or are we totally off base? Those kinds of things can be very, very helpful. You are going to need clinical, fiscal, and leadership teams to be part of your negotiation team. Again, this is contract negotiation. Along the way, discussions are going to break down. You're going to hit snags. So you want to make sure you have sort of a predetermined team that you can bring some of the thornier issues to and say, hey, look, the payer is going to walk if we can't figure this out. So we need leadership to come back in and massage this through. So not building that ahead of time will come back to bite you. There are a lot of really great software options out on the market today that can help you actually model out the contracts. We highly suggest the utilization of these kinds of softwares. You can do it, old school on an Excel spreadsheet. That's totally doable. But as you go through the contract negotiation phase, as folks are kind of talking about the different terms, hey, we want to, reduce the stop loss corridor. You want to be able to model that in real time so you're not reacting necessarily to just a proposed change. You're actually modeling that on your current population so you know, yeah, that's fine. That's really not going to affect us, or yeah, we can't actually agree to that because that's going to increase the risk we could face with this. So the software is out there. It's inexpensive. We always encourage folks to use it. Utilizing robust project management supports and techniques. This is one that I see, and we'll get to sort of a list of common things that I see go wrong. I see this go wrong all the time. It's sort of like the clinical staffs have come together, they've agreed on a model. Okay, great, like let the lawyers go forth and do this. That is not how value-based contracting goes forward. You need really robust project management capacity. Ideally, someone who's not involved in the negotiation, who's keeping the contract negotiation on track. The other thing that I always, it's a big hint for people, and this is, I always say Q4 is our busiest quarter. Why? Because plans want to be in contract that start on the first of the year, right? They want that calendar year synchronicity. So if all of a sudden you get started in November, you're probably not going to make it to the end of the contract and implementation by December 31st. So, but the same thing goes for January 1. If you start a contract negotiation on January 1, there's a lot of dawdling that goes on because no one's feeling all that pressure. So this is where you need the really, really heavy project management to come in and help that. Leaders meetings, this is a tactic that we use if you feel like you're coming to an unsolvable issue, making sure you're bringing in both clinical and fiscal leaders to the conversation to make sure that the negotiation doesn't break down. All right, so now that you've done all that, here's some strategies for success that we wanted to share with you throughout all of the work that we do negotiating value-based contracts. The first strategy is to really understand payer pain points, especially if you are on the provider side. We often see that providers, rightfully so, they live in their own world and they're not necessarily attuned to what the payer is struggling with. And this is a pretty basic thing to get right. You can kind of poke around and ask people, but there's also lots of documentation about what are payers struggling with. But we often see that providers rarely take the time to ask those key critical questions. What we see this lead to is a lot of wasted effort. So both parties will come to the table, we'll be talking about something, sort of at the 11th hour, the payer is like, yeah, this doesn't actually meet my pain points. So I'm actually just gonna jettison this and walk away from the table. So make sure you establish those very, very easy. Have some examples here for you, right? Key areas of HEDIS underperformance. How is the plan doing? That's typically available publicly. Are they facing network adequacy problems, right? Do they have a rural area of a state or a region that they are really struggling to get providers into their network? Could you offer them the ability to grow their network? That would solve one of their problems. Ask them about fast-growing cost categories. Prescription drugs is always on the table there. The other one that I think is not thought of enough is regulatory challenges or reputational challenges. So maybe this is a payer or a provider that more recently is in the news. It is worth just Googling the provider or the payer to see, have they been called out more recently for X, Y, or Z? How can you help them fix that? How could a contract really enable some reputational points in their bank, I could say. Second strategy is being data-driven, and I was just having a side conversation about this. Both on the provider and the payer side, there is an assumption that the other party really knows what their data looks like and really understands their performance. That is 99% of the time not true. And so what you need to do when you're in these negotiations is, if you're on the provider side, you really need to bring data that says, like, we know we can impact this. Maybe you're going into, a diabetic model, right? Maybe you had a pilot last year, and yeah, it was only 100 people in that pilot, but you showed that you can reduce total cost of care and bring those quality scores up. So bringing data into the conversation really can help you accelerate the conversation and time to contract. It doesn't necessarily always have to be claims-based. That's the other thing. Something like a net promoter score, right? Communicating to the payer, yeah, we want to work on this with you, but part of it is because we know that people who come see us, they feel really good about the care they get here, and they're more likely to stay on the plan. They're more likely to come in for the care that they need. You should also be willing to commit to data collection and have a data or evaluation strategy. We are definitely seeing in the value-based space, a lot of large philanthropies are circling the waters on VBP, so they can't be in the negotiation phase, right? They're not a provider or a payer. But they are willing to fund an evaluation. So you're bringing forward a really novel maternal health model. Well, they can't deliver babies and they can't pay, but they can be sort of this third party, hey, did this model work? Did we actually see lower cost? And they can also, third party validate. So there's a lot of that going on in the ecosystem that is easy to access. The third strategy is being willing to put something at risk. I know sometimes we talk about risk contracting, and we can talk about the advanced models, especially coming out of CMMI like ACO REACH, it's 100% risk, all upside downside. That's often not where providers start, but you can't really be successful if you're saying that you don't want to put anything at risk. So sometimes even just saying, okay, we're going to stick with mostly fee for service, but we're going to put a little bit at risk and learn and really see this as I have a colleague who always calls it crawl, walk, run. It's understandable that especially provider groups are nervous, but the willingness to put at least something at risk can really accelerate the time to contract. Oh no, there we go. Our fourth strategy is using third-party vendors if needed. I think this is a really big thorn in the transition away from fee-for-service to value-based contracting, is that oftentimes the entity does not, and I mean that on the provider side and on the payer side, does not have all of the things it needs to be wildly successful from day one. That's okay. And again, I would not encourage that you go out and build something before you have a contract, right? There's a logical model to this. Get into value-based contracting, learn a little bit about what you do or don't have, but in the interim, you can really use the third-party vendors. Value-based contracting has spawned a whole sub-entity of both software and service companies. They are really good interim tools that you should use. We often say if you are a larger organization, especially provider-led organization, Over time, you're going to want to build those internal capacities, but you may not be able to get up to speed on a really fancy data analytics tool in 6 months, right? So use a software tool for the first year or two, come to understand what you and your organization need, and then you can turn to building internally. There's lots of technology tools out there. This always comes with a vote of confidence and a warning. A lot of them are really good, but make sure you're not falling into that trap of assuming that technology will fix poor clinical quality, because it won't. If the point of care does not change, no amount of fancy software is going to change that for you. So just make sure you know what problem you're trying to solve with the tools that you're using. Our fifth strategy is, making healthcare a team sport, making sure you're partnering. When fee-for-service has sort of corrupted the base, healthcare delivery system, we look at patients as competitors, right? We look at other competitors in the market. We can't possibly partner with them. We can't possibly work together. It is more helpful when you're in value-based arrangements to say, okay, these individuals are no longer my competitors. We should work together. I should figure out how we can deliver services, how we can deliver value in a much better way. But collaboration does not just happen on its own. I hear a lot of like, well, if only the hospital would do this. Well, have you gone down there? Do you know who the discharge nurses are? Have you asked them about their process? Because they may be sitting on the world's best idea, but they have no one to tell it to. And so you can't just wait for partners to come to you. You should really go to them. When you're talking more about sort of provider partners, legal structures, IPAs and ACOs have definitely proliferated. It sort of feels like, at least in New York State, you have one on every street corner, just like a Starbucks. But remember that these are just means to an end. You can't just put a bunch of providers in an IPA and expect good collaborative behavior. It will not happen. So you have to have dedicated resources to building that collaborative behavior. Collaborative value-based contracting is harder. We're not going to sugarcoat this for you, but it's far less risky, and you should absolutely consider this before just going it alone. You also can think about expanding collaboration past the borders of healthcare. Social care is a huge component of why we see bad outcomes. So how are you reaching out to social care providers in your network, in your provider's core geography, to make sure that they can help you and address the SDOH needs of patients? I work a lot on that last point, sort of building cross-sector partnerships. And the funniest thing I always see the first time we get clinical and non-clinical partners in a room is, everyone's being very cautious of not sharing patient information. And so they'll say, well, I have a patient who, and within 5 minutes, someone goes, I know who that is. Because the patient that you're frustrated about is the patient that the homeless shelter is frustrated about, is the patient that the county is frustrated about, is the patient that the library, the public library system sees day in, day out, right? We know these individuals. We may not know their full story, but the second you get people together, they can ID these individuals without even telling you their first name, last name. So it's incredibly, incredibly powerful. So we wanted to share some of the most common errors, or just some of the things I see most oftentimes going wrong. And I'll share some from the provider side, and then I'll share some from the payer side. On the provider side, the first thing that I see is the assumption that the sales cycle is short. So sometimes people will reach out and say, hey, we'd love to do value-based contracting. We'd love to contract with you, a consultant to help us do this. How's 6 months? Like, 6 months can go a long way to planning what it is you're going to do. But if you go into this assuming that the sales cycle is short, you will be blindsided and you will be very frustrated when 18 months later you cross the finish line. The second thing I see on the provider side is assuming that the payer party has a great handle on their data. And this just comes from being on both sides of negotiations, is both parties think the other party is either way more insightful than you are, or is withholding data. The truth is often no one quite has their data shop where it needs to be, and so it leads to misinformation on both sides. The other thing I see on the provider side is folks reading into the negotiation a little bit too much. So maybe a meeting was canceled, right? Maybe the payer says, hey, I gotta push this off a week. That data request that I put into my team, it didn't come back. And the provider goes, see, I knew they didn't want to contract with us. I knew it. You got to kind of like acknowledge the hurt on the side of the provider. They have often been in bad contracts before, but it is really helpful to just bring down the heat in contract negotiations a little bit. It is often technical challenges that stand in the way, and if we allow too much of the ego or the hurt feelings to take over, folks will walk away from the negotiation table. Assuming the payer will just bulldoze them into a bad contract. Thing I like to say to my clients is, well, not with that attitude, right? If you go into a contract negotiation assuming that you're going to get bulldozed and you'll have no say, you will get bulldozed and have no say, right? This kind of goes back to, we have to acknowledge bad behavior has taken place, but we need to enter into these negotiations, contract negotiations, with a bit of optimism. We covered this before, not researching the other side's pain points. This has happened numerous times to clients. They go in pitching one thing, not having realized that just last week, DOJ just dinged this payer for having done exactly that. So research the other side of the negotiation, make sure you understand what's going on to them. Not being forceful about leaving the negotiation table. This is especially a hard one for providers. I was just this week, in a contract negotiation with a provider who they serve a pretty rural area, and they're getting frustrated about where the contract negotiation is. And I said, you can walk. There's no rule that says you have to be in contract with this insurer, but let's think that through. That insurer, absolutely, if they lost you, they would be out of network adequacy requirements. So we have to sort of teach on the provider side that there are tactics in contract negotiation that you can use to get things accelerated and on track. The last one is not asking for any data or enough data. Absolutely the most transformative piece of value-based contracting is the fact that every piece of the contract should be transparent to both parties. So when I have a provider who tells me, well, I was in a contract and it had a target budget and I don't know how that target budget was calculated, you are not doing value-based contracting right. You need to have direct access to data before you sign any kind of contract. You cannot go in assuming that the other party has done the right kinds of data analysis and simply take what you are given. On the payer side, these are the most common errors that I see. The first is assuming that the sales cycle is short, and coming once again to payers. I have clients, I have provider clients who, it's November 2nd, they just got to reach out from a plan. So this assumption that it won't take very long to get into these contracts, it's on both sides, and just making sure both sides are very clear about this is very helpful. Payers also assume that the providers have a great handle on their data. They assume that providers know which populations are falling behind, which populations are exceeding cost. They do not know. Both sides need to acknowledge they don't have a great handle on their data. On the payer side, one of the most frustrating things I see, and one of the things that hampers progress, is a delay from the payer in sharing data. I know this can feel scary when a provider says, I need 3 years of total claims files untouched. But that is the way forward. We have to give this data over to providers in order to unleash their innovation and their ability to understand what's going on with patients. Not providing short-term supports for long-term gains. I think oftentimes providers, especially if they don't have experience in value-based contracting, they're looking for short-term support. So maybe year one is an exploratory year and there's no downside risk, and they want a little help from the plan or payer to help them get through that first year. I often see payers sort of cut their nose to spite their face. So they'll say, no, you know what, we're going to do this and it has to have downside risk, or we're not doing it at all. That's going to harm you in the long term. So really, again, this gets back to being collaborative with your provider partners to make sure that you can actually achieve your long-term goals. Seeing the process as oppositional instead of collaboratives, plans are not really used to being great collaborators. This is a new muscle for a lot of plans, especially for sort of network contracting folks. So we always account for that, but this is definitely something that I see the payers not leaning into enough when they go through this contract negotiation phase. So I know that was a lot, but I wanted to give you sort of a very high level view from theory and sort of why are we even doing this to how do you get started, how do you start negotiating these contracts, to some of the most common errors I see. So I will do a time check with someone, and we have 10 minutes for questions if anybody's got a burning question. Oh, in the corner. Oh, no, Ed. Yeah, so the question is around sort of like, once you have, let's just sort of assume like you have a population, you have a problem you're trying to solve, you have a willing partner. Sort of like, now what? How do you get started? How do you make sure you're approaching those payers in a meaningful way? So I think the first thing is, and I know I sound like a broken record on this one, but it's like making sure your time frame to contracting is realistic, right? So not showing up on a payer's door and saying, you know, today's November 2nd, we're looking for a contract that goes into effect Jan 1, right? Like that's not setting you up for success. Again, going back to the documentation, if you can document in just a few slides very clearly, these are the things that we want to achieve in this value-based contract. We think this subpopulation can get better quality measures, and we think we can reduce cost over this period of time. Having that really, really clear framework. And then the next hardest piece is just asking, which I always find fascinating, right? Folks are very nervous. They don't want to go into a meeting and feel like they don't have everything sorted out. The biggest thing is to figure out, especially if you're on the provider side, figure out who at the plan is really being tasked with value-based contracting is a really great piece of research that you can do. I'll let you in on a really big secret. Most of the folks who have been given the responsibility to execute value-based contracting on the plan side, they're also new to value-based contracting, right? So they may not have been doing this for the last 20 years, especially if you're dealing with a smaller regional plan or a subsidiary of a national, right? They are learning as they go too. And so for both parties, and that's what I mean by sort of like turn the heat down a little bit in these conversations, reaching out to that person and saying, hey, you know, Joe, I see that you are now the lead for VBP at X and YZ plan. We'd love to talk to you because we think we have an idea here, but we want to hear from you. What is your plan looking to do? Do you have specific VBP goals? And sort of when can we talk? And a lot of that like initial exploratory conversation will unearth so much about what the plan is trying to solve for. I'm also just a big believer in radical candor, asking the plan, you know, hey, for this provider group, what is your main pain point? That oftentimes, one, will elicit like a couple minutes of silence as they decide whether or not they want to say the honest truth. But a lot of times they'll just come out with it and say, yeah, you know what? This provider has been a super challenge for us. We don't quite understand what's going on. They've had leadership turnover. They're, you know, we look at their MLR and we know it's way out of whack. They have really high spending, but we don't know what to do, right? Anything that you can get to accelerate those honest conversations very, very early on to help you craft a better and better model that then you can go to them for. My other big suggestion with plans, you have to figure out the internal structure of a plan. That is one thing that I just see providers miss constantly. Is this a national plan that it has a federated model, right? So maybe they're a big national plan, but they allow every state to kind of run in their own regards. Are they a highly replicable plan? So they have a national office, and if you don't have the document that the national office signed off on, you're not allowed to do anything. Better understanding what the plan, how the plans are actually structured also accelerates your time. Because if you're talking to someone who's in a highly replicable, you know, nationwide plan and you're bringing your own contract to them, they're never going to be able to sign it. So just either figuring out that information ahead of time, you know, using expertise in your network to figure those questions out, or just asking that right off the bat. Hey, do you guys have a standard VBP contract template that you're required to use? If so, can I see it? You know, I just want to wrap my head around how you guys are looking at value-based contracting, I think is two big pieces. Yeah.
Have you ever seen incentives used for like hospital administrators by their boards or to utilize more value-based contracting as a means
Yeah.
compensation for administrators?
That's a great question. There's a couple layers to it. So as you think about business lines for payers, right? So the Medicaid program being a state federal partnership, different states have different expectations. So I'll just use New York State as an example. New York State went from having, sure, there were very, early value-based contracting going on. But when the state Medicaid program said, we have 7.5, I think 8 million lives on Medicaid today, 80%, by this period, 80% of your payments have to be in value-based payment. The plans sat up, right? So all of a sudden there was a lead VBP person in all the plans. That person was, going around to conferences, getting really smart about it, right? Like it accelerated the ability of the plan to actually come to providers like hospitals and say, hey, this is what we're going to do. So in the Medicaid space, you have that, right? In the Medicare space, obviously, like leaving MA aside for a second, right? You have all of these at-risk models coming out of CMMI. Those are very prescriptive. So they have very clear, and it's worth, spending some time sort of learning the broad outlines. What is MSSP? What is ACO REACH? What are the bundled payment programs? Then you have commercial. Commercial's been the slowest to adopt VBP for various different reasons. But I do think as the cost goes up, you're going to see more and more pressure. And we actually have seen pressure from large employers with plans to say, hey, we can't just face a 10% increase every single year. So that sort of lays out your business lines. Getting back to your example of a hospital or a provider group, I haven't seen specific examples where the hospital board says, we're offering this bonus. Let's take a look at, I'm going to make this up. 10% of our contracts are value-based. By 2025, we want 10%. And we're going to tie specific, bonuses to it. I haven't seen it. What I have seen, large provider groups, they do a benchmark analysis. They say, okay, how many of our contracts are value-based contracts? How are we performing in those contracts? And we're going to talk a little bit later today about the incentives that hospitals face and why hospitals should not wait to get into value-based contracts. But what I have seen is they'll do a benchmark analysis. We're at 5%, and it is our intention to get to 20%. Now, what they do with the incentive structure, that's sort of, their own kind of internal business.
Part two.
Yeah.
Different question. In 501c3 hospitals, the hospital is the payer, right? So, for charity patients. People are not coming by Medicaid. Have you seen any examples of just assume the hospital pays the doctor,
Yep.
For seen any sort of value-based arrangements between the hospital and its employee doctors and allied professionals for value-based care for the charity care patients that essentially is funded?
So what your broader question, and then we'll get to the example, is if you are an employer of physician and clinical, right? We'll just say physician, but let's just broadly say clinical employees. Right? Value-based contracting is all about aligning the incentives between the payer and the provider, and that's like writ large, right? If all you do is that, and I had a client who they understood this so clearly. They were getting themselves into advanced bundled payments, very high levels of risk, right? Lots of opportunity to really bring down, and they were already they were a high quality provider. So they knew by flipping into value-based contracts, they would have higher margins on this business, like point and blank, right? What they also understood is if all of the revenue of that agreement just falls to the bottom line of the organization, you will see some change in individual practitioner, right, clinician stocks, but you will accelerate that 10x if you then take the next step and institute different models of payment for clinical workers. What that looked like is they moved away from an RVU model, and they basically said, yeah, base compensation, they were employed, right? So base compensation, and then at the end of the year, we're gonna look at your performance in these value-based contracting arrangements that we have with payers we'll just make up some number, right? It was a 50-50 split. So they get to keep 50% of shared savings, and they pass 25% of that directly onto the doctor, and this is a bundled model, who did the surgery. So they sat down, all of their physicians, all their surgeons, and this is where it gets really important, and this is hard to do, but important. You have to model that out. You have to say, and I'm really just making up numbers, you make $400,000 as an employed physician, you have the potential of making another $100,000 through RVUs. We're going to move to a model where you make $400,000 as an employed surgeon, and this is your opportunity, whatever that number is. This is something I see people fall down on all the time. They simply tell their providers, you'll make more money. Your lives will be easier. If you can't actually quantify that for people, there is less motivation for them. I will say ACO REACH is a really good example of this because the new CMMI model, ACO REACH, is on an NPI basis, not on a TIN basis. So we had a couple clients going into REACH. We produced, and there were three slides. This is what you make today in fee for service, right? I look back at your billings. This is what you make. This is what you would make in ACO REACH. And there's a net positive. And when I tell you that accelerated conversations like nothing else, so replicating that is really, really important. So that's getting to your question. Your question about charity case, yes. Oh, your question about charity case is a complicated one, and I'm getting the signal that I am out of time. So I will answer that with you one-on-one. Perfect. Thank you so much, everybody. Appreciate it. And we'll look back to